Everybody. My name is Sean Phillips. I'm the Head of Health and Social Care at Policy Exchange, and it's a really great pleasure to welcome you all here this afternoon for the first event in our Fringe programme at Conservative Party Conference this year. And the question that we're asking is a diagnostics revolution the key to improving the NHS? And I'm delighted to say that we have partnered with Alzheimer's Research UK for this afternoon's discussion. Now, from the possibilities offered by point of care or at-home testing that many of us were experienced and used over the course of the pandemic, to the development of community diagnostic hubs that look to put diagnostic equipment far closer to people's homes in their communities. Really great strides have been made when it comes to diagnostics in recent years to boost the variety and the convenience of diagnostics across the NHS. And the NHS is now delivering over 1.5 billion diagnostic tests overall a year, and demand is growing quite considerably. Endoscopies over 5% increase year on year. So this is an increasingly significant activity and challenge for the NHS to deliver. But also there are, as I say, really great opportunities through new innovative approaches in where diagnostics sit in the pathway and new hardware coming on stream. So we want to look at how the UK can maximise on the promise of early detection and improved outcomes across key conditions, including dementia and cancers. And we want to ask, to what extent does actually boosting diagnostics and making the most of it hold really the key to improving the performance of the NHS overall? So to consider these questions, we've convened a really fantastic panel. To my right is Neil O'Brien. He's the Minister for Primary Care and Public Health in the Department of Health and Social Care, previously a Minister in the Department for Levelling Up Housing and Communities. He was first elected Conservative MP for Harbour in June 2017, and also formerly of this parish, formerly a Director of Policy Exchange. So always a pleasure to welcome you back, Neil. On the far end is Dr. John Dean. He's the Clinical Vice President at the Royal College of Physicians and also a Consultant Physician and Deputy Medical Director for Transformation at East Lancashire Hospital's NHS Trust. And he works clinically as a consultant physician in acute and general medicine as well as diabetes. To my left here is Sarah Neville. She's the Global Health Editor at the Financial Times, covering both NHS policy but also healthcare developments across the globe. And last but not least is Dr. Susan Mitchell, who is the Head of Policy for Prevention, Early Detection and Diagnosis at Alzheimer's Research UK. That's the leading dementia research charity in the UK. And she leads the charity's policy development and engagement to improve early and accurate diagnosis for dementia and working with multiple stakeholders. So in terms of how we'll run the session this afternoon, I'll be handing over to each of our speakers in turn, beginning with the Minister. They're going to deliver strictly up to 5 minutes of opening remarks. And then we'll discuss some of the key issues that are brought up across the panellists for about 15 minutes. And then it's over to you for the final 15, 20 minutes question and answer with the audience. And our only house rule here at Policy Exchange is that we have a mic. Please wait for it to come to you if I point you out, and then you must state your name and organisation before delivering your remarks. So without further ado, delighted to hand over to the Minister.
Thank you very much. Ladies and gentlemen, thank you very much for being so keen and coming to the very first event of conference. I certainly feel a lot more healthier than the last time I was on a Policy Exchange panel. The last conference where I'd got really serious food poisoning and I was struggling in space at the end of it. And the worst thing was that it was the first event of the day, so any normal person watching would have assumed I was just terribly, terribly hungover. So if you were there, I apologise. I really was ill. The story of health is really the story of a kind of an unstoppable force and an immovable object. On the one hand, we've got 267,000 more people working in the NHS than we did even in 2010. In real terms, we spend about 3 times as much as we did over the last 30 years. And we're spending a bigger share of a bigger pie in terms of GDP on health. That's the unstoppable force. The immovable object is the ageing society. And the economics of it are stark in a way that I think still, even after 30 years of discussing this, a lot of people still don't understand. So the average health cost for a 16 to 45-year-old is about £1,000 a year. For someone who's just retired, 65 to 76, it's about £4,000, big jump up. And then for those of you who are over 86, it's £10,000 a year, so 10 times more than those kind of younger adults. And the number of people who are aged over 85 is going to grow by about 55% by 2037. In my part of DHSC in primary care, I can feel the pull of it. So GPs are doing about 15% more appointments every day than they were before the pandemic. Huge amount more appointments. But someone over 70 has 5 times more GP appointments than someone who's a young adult, 5 times more. And there's 30% more of them than there were even in 2010. So this is the pressure that we are under. And so if we're going to survive, we're going to save the NHS, the only way we're going to be able to do that is if we do things really quite radically differently. And the 2 big criticisms you always see of the NHS are that it's firstly too slow to adopt and diffuse new ways of working and new technologies, and that there's too little prevention, too little screening, too little diagnostics, and too much expensive secondary care as a result. And that's the subject of our panel today, really. So what are we doing to get more diagnostics, more prevention at an earlier stage and save ourselves money in the longer term? So we're rolling out community diagnostic centres, which Jez already alluded to. We started just 2 years ago. We now have 119 of them. And in politics, the things that go right never attract any news, and these CDCs are one of the things that's definitely gone right. Now about 5 million people have had a diagnostic test in one of them. A lot of them are on the community estate, so they're much closer to people than they would be if they were in a big hospital. Some of them are literally in high streets, and so they're getting diagnostic checks much more easy and quick. And that is part of a wider thing, which is the biggest ever investment in CT and MRI scanning. We're going to have about a third more of those things as a result of the decisions we made in SR21. So huge growth in diagnostics and lots of new ways of doing them too. So hands up in this room if you have had your NHS health check. We offer this to everyone over the age of 40. Who's had the NHS health check? You've got a handful, a light smattering. Now, it's a wonderful thing that is key to our prevention efforts. But the truth is, at the moment, a lot of people, because it's not convenient, you're all busy people, you don't go to the GP when you get the letter. So we're introducing the new digital health check, which will let you do a lot of it on your phone. We will post you a diagnostic for your cholesterol you can use at home. It's a finger prick test, and we'll signpost you to somewhere we can get your blood pressure done. And we hope that will help a huge number of extra people take that potentially life-saving test that can tell you if you've got hypertension or other serious health issues before they become a massive problem. And we are trying to also use screening diagnostics to tackle the underlying causes of health inequalities with things like the new lung health screening that we are rolling out. We see that we're going from catching about 1/4, sadly, of cancers at the treatable early stages to 3/4 by having tests that are focused on ex-smokers and current smokers, particularly in areas of deprivation. So we are reversing some of those health inequalities using diagnostics and screening. And similarly in cancer, we're using the huge rollout of FIT testing, which is so-called stool testing. You go, if you've got the symptoms of bowel cancer, potentially your GP increasingly will give you this little pot to take home, simple diagnostic, and it completely changes the way that the workflow works in the NHS. Only about 2% of the people who use those kits actually need any further follow-up. But a radically larger proportion of those who then do go on to hospital are diagnosed with cancer. So we are using that filter to make much more efficient use of our resources and get people reassurance quicker. And in terms of cancer, there's huge amounts more that we can do. The company Grail have this thing, the Gallieri test, which is a blood test for about 50 different types of cancers. It's currently in a late-stage trial. We have said that we will buy about 1 million of them, assuming that it passes that test. So huge amounts happening on cancer, but obviously not just on cancer. Even on things like HIV now, you can use increasingly convenient home blood tests. We sent out about 22,000 HIV tests during HIV Awareness Week last year. And we're increasingly seeing the growth of new ways of analysing those tests too, the growth of AI in diagnostics. There's a fascinating new company called Brainomics where through stroke networks we're increasingly seeing those scans that you take in hospitals if someone has a suspected stroke being analysed by AI, much better, much faster diagnosis, much quicker treatment as a result, and that is taking the proportion of people who recover almost entirely up from about 16% to 48%. So absolutely transformational, not just the type of screen you do, but the way that you then analyse that screening using new technology. So huge untapped potential from diagnostics and screening. It's got to be the future. health is the subject of something called Baumol's cost disease, which is basically a posh way of saying that stuff involving people gets more expensive compared to stuff involving stuff over time. And so if we want to escape from Baumol's cost disease, we've got to try and do more with new technology, more with screening. And there's a lot more we can do. We can have a discussion today perhaps about how we improve clinical trials, how we get more rapid rollout of new technologies, faster testing and diffusion of ideas, how we increasingly weigh health spending towards prevention. Some interesting ideas about that in the Hewitt Review recently. So I'm keen to take part in the debate. I'm mainly here to sponge the ideas off the other panellists and off of you. And so with that, I have said my bit. Thank you, Chair.
Well, thank you very much, Neil, for those opening remarks. Lots to pick on. We will do in the ensuing conversation. Perhaps if I could turn to John next, and then to you, Sarah, and then lastly to Susan.
Yeah, thank you. Thank you very much indeed. So I am Clinical Vice President of the Royal College of Physicians. So we represent around 40,000 physicians, largely in the UK, but also internationally, who work in hospitals and in communities, often leading teams of healthcare professionals and working very closely with other healthcare professionals in other clinical areas, and also working closely with primary care and public health, and many indeed in leadership roles, in policy, in leading hospitals, in leading healthcare systems. So we cover a broad breadth. In terms of our challenge today, in terms of early diagnostics and how that might change the health of the population, but also how we deliver care, there are a number of inextricably linked challenges in this area. One that's already been touched on is health inequalities. So I work as an acute physician, and we know that around 30% of people being diagnosed with cancer at the moment are diagnosed when they present to hospital acutely. And it's very similar with heart disease and indeed with dementia. And when you look at these people and you talk with these families, there's no doubt that there have been symptoms and signs for a considerable length of time before that. But most of them do come from deprived communities where they're vulnerable, where they may be socially excluded, where there may be barriers currently for them to access healthcare. That might be down to their knowledge, their awareness, their self-advocacy in terms of getting help, or it might indeed be access to care for other reasons. So these are some of the challenges we have to make. And we're certainly the approach that's been taken with lung cancer screening is the sort of approach that we need to take much more widely, where we're targeting, the vulnerable. There have been some other interesting areas, for example, with hepatitis C diagnosis, where people who are very disadvantaged in prisons, homeless, etc., have been screened, treated, and indeed cured of a disease that would kill them and could spread to other people. So there are some great examples. So health, we have to look at this with a health inequalities lens so that we're targeting early diagnostics on those who are most vulnerable. We cannot separate diagnostics from workforce. Workforce is the biggest challenge in the NHS and indeed in many other sectors at the moment. So the kit is great, but the kit interacts with humans, and a diagnosis is made by interpretation of that test with the patient and their experience and their diagnosis in order to get the right treatment or advice, either for prevention of progression or indeed treatment of the illness. So if you look at cancer pathways at the moment, for example, the 2-week cancer rule that we used to have, only 7% of people referred for specialist opinion on that will be diagnosed with a cancer. That's a huge workforce. It's one of a huge amount of work. If you look at endoscopy, which is one of the rising areas of demand, again, very low rates of positive diagnosis, and yet tremendous weights there because the demand is increasing at a very rapid rate. And things like the fit testing and how we use that will make a difference. But we have to grow the workforce, and we have to use the workforce in a different way. One of the biggest challenges with the workforce is people leaving the NHS, and those are often the more experienced members of the NHS, and those are the most fundamental in some of the complex diagnostic processes, and indeed in training the future workforce. So how we retain them is essential. pathways for diagnosis and treatment is an essential approach to this. Again, you cannot separate the kit from the people, and indeed the AI from the interpretation of that into clinical practice. The Royal College of Physicians are working very closely with NHS England at the moment on a 5 to 10 year strategy for transforming what we currently call outpatients. So for many diagnoses, people are referred from primary care to specialty care and then are seen by specialists in one form or the other. And there are some really good, innovative examples of how those pathways have been changed with early diagnostics, use of patient screening and questionnaires, better integration with primary care. What we're certain of from that work is that the more traditional pathways need to change. We need to move from thinking about single episodes of care where patients may see a specialist or a primary care practitioner to pathways of care, many of which are patient-driven, coordinated by pathway coordinators so people get early diagnostics, early interpretation, and then shared decision-making about what treatments they need. And then finally, a little bit of a cautionary note. And that cautionary note is around overdiagnosis and over-treatment. So we are in a situation where we can do more scans, more tests, but we would estimate that at least a third of those, maybe up to half of those, are unnecessary and not actually helping the patient. So it's great to do earlier tests and to get those to the people who most need them, but we have to be cautious that we're not over-testing people and then over-treating people because of illnesses that may not progress, may not affect their health, may not affect their well-being, but actually those treatment paths may significantly affect their well-being in terms of anxiety and their concerns around their health. And then the final point is around the wider benefits of early diagnosis, early treatment for prevention of progression, and that is an economic factor in terms of the the positive elements of people's lives when they are well, from health promotion, from early detection, from early treatment, keeping them well, keeping them functioning, keeping them economically active. For every £1 of healthcare expenditure, the economy gains around £4. So we cannot separate people from kit. We need more people. We need to focus the diagnostics on those people with the greatest need and ensure appropriate diagnosis. And through that, we can have a much more viable health and care system and indeed have much wider benefits on society. Thank you.
Many thanks, John. So Sarah, over to you next.
So I was going to set the slightly bleak backdrop to this discussion, which is that we've all become used to NHS targets being missed by very wide margins, but the figures around diagnostics really are very striking. The operational standard is that no more than 1% of patients should be waiting more than 6 weeks for a diagnostic test, and that was last met almost exactly a decade ago. And in the last year, because I checked the latest NHS England figures last night, the proportion of patients waiting 6 weeks or more for tests like endoscopies, barium enemas and MRIs has varied between about 1 in 4 people in March this year and 1 in 3 last December. So that's a very long time to wait for a test which could either confirm or rule out cancer. You know, that more than 6 weeks is going to feel like a very, very long time indeed. I mean, late diagnosis of cancer is in itself a sort of British disease, I would say. And while there are obviously a number of different reasons why comparable countries seem to do better than we do in diagnosing cancer at early and more treatable stages, it's hard to imagine it doesn't have at least something to do with where we stand in the international league table on scanners and other vital diagnostic equipment. Now, I heard what Neil said earlier, that a significant increase in that equipment is coming. But right now, on CT scanners, we have fewer per head of population than Turkey, Latvia or Russia. On MRI scanners, we're lagging behind Lithuania, the Slovak Republic and Slovenia. And it's striking, perhaps, that we often talk about the capital shortage in the NHS, but we tend to think about crumbling buildings, don't we? But of course, the failure to invest in vital equipment like this has been equally damaging to productivity and the ability to save and to prolong lives. So how can we change things to realise the potential of improved diagnostics to ease pressure on the NHS and keep us all fitter? Well, that comes under various headings for me. The first is infrastructure, not just equipment, as I just mentioned, but laboratory capacity, which we'll need, obviously, if we want to move fully into the territory of, sort of precautionary testing, perhaps, for diseases, some of which, of course, already happens with bowel cancer. That fit test, Neil, of course, gets sent out automatically to everybody over 60, receives it in their own homes. But here, I had thought that the pandemic had really set us on a particular path. I thought it was fascinating that, albeit after rather a bumpy start, we did build a very big national capacity in laboratories, didn't we, in testing capacity, processing capacity. And but actually, a lot of that seems to have been wound down now. And I understand the reason for that. Obviously, you can't keep vast amounts of capacity when we're no longer in the middle of a pandemic. But it is a question that will need to be thought about, if we are going to pivot much more towards testing, wider range of diagnostic testing will need a way of processing all those tests. John has already touched on workforce, but I'll perhaps just mention a particular part of the workforce, which is in relation to genomics. So much of the promise of early diagnosis, I think we'd all agree, stems from the work that we really excel at in this country on the human genome. And it's here that the technology really does offer an opportunity to shift the focus of the NHS from reactive to preventive healthcare. And I recently spoke to Professor Matt Brown, who's the Chief Scientific Officer at Genomics England, and he, talked to me about how there's enormous potential in genomic sequencing, for early diagnosis of certain types of heritable illness or to screen for the risk of cancer and other diseases. But if all newborn babies and everyone over the age of 70 were to have their genome sequenced, which is what he felt would be ideal, to check for susceptibility to disease or the likelihood of an adverse drug reaction, it would involve more than 500,000 people a year. And he said at the moment there wasn't any plan to get us to that. And in particular, there weren't yet nearly enough clinical scientists who are needed to interpret the genomes and report on the data. And this was one area where he said AI wouldn't ride to the rescue in his view, because apparently this is one of the few big data areas where analysis is still pretty much a sort of manual cottage industry, and there aren't yet widely used AI-enabled decision support software tools that can help that. But I think, sorry, forgive me, Sean, I didn't notice when I started talking, but tell me to stop if that's done. Am I all right? Oh, good. So the important thing, of course, John will agree about the rollout of this kind of technology is that it needs to be done in a way that doesn't put even more pressure on the NHS, which is already so hard pressed. And I think one very interesting model of how that might be achieved is happening with Grail. Neil mentioned this fascinating blood test, which seems to be able to screen for cancer. It's still being piloted. We haven't yet had the full evaluation, but it looks promising. And its rollout is being directed centrally by NHS England. It doesn't depend on agreements being struck with individual integrated care systems, and the tests are being carried out in mobile units rather than hospitals or GP surgeries. So essentially, the NHS tell me all the risk is being borne by the company. And I think that points to the importance of developing partnerships with life science companies to pursue the preventive diagnostics agenda in a way that doesn't overburden the NHS. And there's other examples of that. So, yes, there's an awful lot more for us to explore in this area, but perhaps I'll draw it to a close for now.
Many thanks, Sarah. We'll get a chance to touch upon some of those points. Susan.
Thanks very much. I'm going to be a little bit more specific now and talk to you about what's happening in the dementia space. It's been really interesting listening to the other speakers, and there's lots of hope. Dementia's in a very different place, but I think it has its own hope as well. I think I'd argue we are facing a diagnostic revolution for dementia, which is a really exciting time for the field. Up until very recently, we've had no treatments that would delay the progression of the disease. So if you are diagnosed with a disease that causes dementia, you will die of it, and it's the leading cause of death in the UK. The field is at a tipping point because we're seeing the first new treatments coming through. They are in regulatory review at the moment, so we don't actually have them in the country, but the first one has been approved in the US. We'll have to wait and see what happens in the UK, but I think the field is feeling really optimistic. Why does that matter to diagnosis? Because it changes what happens. Currently, there are 1 million people living with dementia in the UK. In England, certainly, only 2/3 of those people even get a diagnosis. And they mainly get a diagnosis of dementia. Now, dementia is the umbrella term for up to 200 different diseases that cause dementia. I'm being facetious here, but we wouldn't accept someone being told simply they had cancer. And we would argue that with a diagnostic revolution ahead, we shouldn't expect people simply be told they have dementia. The new treatments that are available are that pull-through for why diagnosis needs to change. We need to diagnose differently because actually the treatments are only going to be suitable for certain people. They need to have Alzheimer's disease, which is the most common form of disease that causes dementia. And you need to diagnose it differently. Currently, most people are offered a memory test, which is fine. It measures the symptoms of whether or not you're facing memory loss and other cognitive problems. That doesn't tell you whether you're going to be eligible for the new treatments, which will actually start to slow progression and give people hope. So we need to actually enable diagnostic access. The good news is there are diagnostics available. They're not routinely available, and we'd like to see that changed. So the two key diagnostics, they're quite specialist. We've got a PET scan or to have a lumbar puncture to take cerebrospinal fluid. And what's also exciting is in future we think there may be blood tests that would be suitable. So there's lots of change ahead in the field, and that's why that's so important. I think it's also really important just for the field because it's a field that's faced a huge amount of stigma. Many people haven't come forward for a diagnosis because they don't see much hope or much point, or they simply think it's an inevitable part of ageing. Diagnosis helps to give understanding to what's going on. It helps carers and loved ones to understand what's happening to their loved person. You can plan for the future. You can access research and participate in research and hopefully access new treatments when they're available. That's a powerful pull why we need to change the situation now. I'm also really mindful and we had conversations or comments here already about the kind of burden, particularly in the role of kind of earlier diagnosis, and that's the case for dementia. These new treatments will be most suitable at the early stages, so we need to be finding people earlier. There's actually possibly, and these are estimates, of up to 750,000 people could benefit from these kind of treatments. It's unlikely to be that many at the start. That's a huge number of people who might start coming forward looking for assessment. There'll also be people, who actually aren't unwell but are worried about their memory or worried they might be developing Alzheimer's disease and also come forward. I think we recognise that's a huge potential burden for primary care and GPs. So that's where there are other innovative diagnostics. There are digital cognitive tests being developed and other techniques which actually we need to enable to be offered through to primary care to help them understand who might be at risk of developing dementia and who's not. And as Neil said, things like the digital NHS health check could also be a really good model for some of this. We need to explore how innovation in diagnosis for Alzheimer's disease and others could actually apply in the real world. So it's a really exciting time. I do want to also just point about how important this is for anyone living with uncertainty about what conditions they're facing. And for many people in dementia, it's a long, hard road towards getting a diagnosis. So I just wanted to take a quote from one of the Alzheimer's Research UK champions, Zach. His father, Imran Shawan, is a gold Olympic medal Olympian, and he's living with Alzheimer's disease. And Zach said, "Alzheimer's is never fun, but understanding what it is and being able to deal with it would make it a lot less painful." And I think we should remember that there are individuals involved with this, and that power of knowledge is so crucial. So to wrap up, I think we are already facing a huge opportunity for dementia. There is a revolution ahead. We absolutely need leadership and support to actually make sure that that diagnostic revolution happens in this country as soon as possible. Thank you.
Lovely. Many thank you, Susan. So many excellent points raised by our panellists. So Neil, in some ways, I'm going to give you the choice to respond to any of the key salient points people have made in the way that you like. But I just wondered maybe, first of all, that point that both Sarah and John have made about the real possibility to actually almost democratise the NHS further, put diagnostics at people's fingertips, allow them to take more control of their health. How do we get that balance right? And what are the things that we really need to prioritise So we actually, as we say, enable that access, but at the same time get that balance right, and we don't create, overwhelming demand on the system amongst particularly people that we might say so-called worried well.
Absolutely. So there's so many useful points already been made. To John's good point, this is exactly why we published the long-term workforce plan, I think the first time that the NHS has ever had anything like that, so that we can start to plan ahead for the clearly bigger workforce that we will need, including in diagnostics and imaging in particular. To Sarah's point, it doesn't change the spirit of it or challenge the correctness of it. We are absolutely seized of the need to get more CT scanners and MRI scanners. That's why we're putting in the extra third. But I would caution against the OECD statistics on these things, because I think there is a massive problem with the stats. All the CT scanners owned by the independent sectors through PFI and so on in the UK, back from previous governments, are not counted in the stats, and for various reasons I don't think they are right. But it doesn't change the point that we don't have enough of the kit. We need more of the kit. We're investing more in the kit. And to Susan's point, which is crucial, which is having treatment completely changes the emphasis and the economics and the argument for doing more with diagnostics, which in the case of dementia is only going to, I'm afraid, become a bigger and bigger political issue in this country. So it is very exciting that treatments are now coming after such a long time, and I think more will come in truth. That I thought during COVID that there would be a vaccine, because when the entire world wants something, it tends to happen. And we are getting there with dementia, though exactly to your point. I think the metaphor about cancer is exactly right, which is it has to be a diagnostic to the exact cause of the dementia for it to be a meaningful route to treatment. So there's a lot already from what's been said that I found incredibly interesting. And I do agree with the point about, got to have not just testing for things, but targeted testing that is a good use of resources in an environment where we'll always be short of resources.
Super, many thanks. And John, one of the things that I wanted to just pick up on, you mentioned sort of the transformation that will take place in outpatients. And we have a real opportunity with integrated care systems now to really take a sort of end-to-end approach to pathways. I just wondered what some of the key things from your perspective you'd like to see the NHS really focus on. So actually there is that ability to be able to shift that focus into the primary care space, be able to do more of this testing, put it at people's fingertips. We've got really interesting examples like Our Future Health and sort of actually placing a diagnostic hardware and sort of the opportunity for testing sort of in a completely different way. So I just wondered what some of your reflections were on the key things that we need to be thinking about moving forward.
Yeah, sure. Well, clearly, the first thing I would say is there's a lot of diagnosis that happens in primary care without the involvement of other sectors, and that has to be recognised, and a large amount of the management then happens in primary care, indeed people themselves. However, a significant number of people, we're in a culture at the moment where we hand off care between one sector and another. So primary care will hand it off to secondary care may hand it back to primary care or to another part of the sector. And we've really got to join those two things up. So actually look at patient need. If the patient has a need for specialist opinion of some sort that can help diagnostic, or whether they need treatment, then that needs to be identified either by the patient or the patient and primary care practitioner together, and an early opportunity then for a clinical discussion around what's needed. If it's really clear that there's a clinical pathway that's required, then that patient can be, for want of a better phrase, plugged into that pathway and coordinated through that pathway. So that then the diagnosticians, which is the clinicians working both in primary and secondary care, can then help the patient once a diagnosis is found or refuted. So we've got to move away from this handoff between the different sectors to actually seeing a much more integrated system where you've got specialist advice coming together with primary care advice who know the whole patient and the whole pathway, and diagnostics sitting in the middle of that to support them. And the other part of that needs to sit in the middle of that is the wider treatment that patients need, because it's not just medical and surgical treatment that patients need. They need wider support. And that needs to sit in between primary and secondary care so that all patients can get it. And at the moment, patients struggle to get the right support because they're in the wrong bit of the system to get it.
Can I just add to that? Yeah. Massive focus is a hugely important point. Huge focus for our primary care recovery plan we published earlier in the year is improving that interface between secondary and primary care, which causes so much grief for people using services at the moment. So we're trying to get it to, by March, that about 90% of practices will give people what's called prospective access to their records. So on your phone, you can see the letter that you might have lost or you might not have seen. And we're doing lots to improve communication between the two. So we had a whole report published by the Academy of Royal Medical Colleges about how to improve this, like making sure there's always a good outpatient helpline so you can get through to the people to find out what's happened with your test. Making sure that GPs and secondary care clinicians can read each other's records so you don't have to chase, you can just find it on the computers, you should be able to. Knowing where you are on waiting lists, having non-public phone numbers so your GP can always get through someone in hospital. We're really, and I'm determined to try and push all that through now that we've agreed the principle over the course of the coming months, and we've got a task for every single integrated care system in the country to tell us what they are doing this autumn. So that's hugely important that this information flows smoothly around the system rather than just causing grief for patients.
And right on cue, I'm going to give a rather shameless plug to one of the most recent policy exchange
doesn't miss
reports.
a chance, does he? Look at him
called
go.
Medical Evolution, which looks
Amazing.
exactly at that challenge between and how to improve the interface between primary and secondary care. So I do commend that to you, and there are copies outside. Sarah, one of the things that you brought up, which I think is a really critical component here, is actually about the life science sector and its relationship with the NHS. I just wondered what some of the key things you thought you'd like to see happening that will actually sort of mature that relationship further, enable, as you say, either the lab space that we're going to need to increase capacity and actually to be able to bring some of these treatments and technologies forward that are going to make a real difference to people.
Well, I think the life sciences sector does find the NHS quite a frustrating client sometimes. They particularly feel that it doesn't always use its heft as a single-payer national system. I mean, in some respects, to be fair, it does, but there's a lot of occasions where companies tell me they have to negotiate individually, with multiple clinical commissioning groups. And this is also the case for companies seeking to do clinical trials, incidentally, that feel they have to get, sort of multiple pieces of authorization, as it were. So, and I heard the other day about an American company that had been very gung-ho about bidding for a contract here, but had sort of ultimately kind of, taken a look and sort of run away screaming, essentially, at the thought of dealing with this, fantastically sort of Byzantine organisation. So I think using the system's power to procure as a single entity, more than it now does would be great. And I think also that the industry feels that it doesn't always know what the NHS wants. It would like to have a much closer dialogue with the NHS about, what diagnostics are needed to serve the needs or the pathways that the NHS feels are important, that they want sort of much more of a dialogue. And I think that the, clinicians, forgive me for saying so, can be quite sort of small c conservative. And I think we saw that with the attempt to roll out inclisiran, the statin, where Novartis, the big Swiss pharma company, had chosen to run a big trial in the UK or in England, and they wound up not proceeding with a trial on the scale they'd intended because GPs who were meant to be on the front line of prescribing and supervising inclisiran were not willing to do it. I think, for many very good reasons, I'm sure, but also partly there seems, correct me, John, if you disagree, but I think there is a certain suspicion of the pharma industry among, among clinicians sometimes, a sense that perhaps why are they doing this trial? What's the, why should I as a doctor be prescribing their statin instead of all the others or the ones I normally prescribe? So I think there are some ways in which the culture needs to become healthier between the NHS and the life sciences sector, I would say.
Can I just, on that point also, I think we know within the dementia field there are real issues because if you haven't diagnosed someone at the right stage, they simply can't join a clinical trial. Right. And we are missing out. Yes. Other countries are getting ahead of this, and actually we're missing out on that trial's benefit to the society, to the economy and society. We have great early research in this country. it's something we're really good at, and it's a shame if we can't capitalise that on that translation and kind of space into clinical trials, which then actually sets things up really well for patient benefit and patient access when it is available. So, diagnosis really bleeds across so many different systems.
Here. We have about 20 minutes left, so I'm really keen to be able to bring in members of the audience and to allow our panellists to pick up some of the comments further. So if the mic is at the ready, perhaps if we just go for the lady at the back who had her hand up first, on the very back row, just there. Please state your name and organisation before asking your question. Thank you.
Thank you. Nicole from Breast Cancer Now. And I just have a question. So talking about community diagnosis centres, mammography, it's not a part of the core specification for CDCs. And because of the way that breast screening and CDCs are commissioned by different teams locally, and they also have different accountabilities on NHS England, there's not a lot of communication and coordination as well. So this means that all this incredible investment that is going to CDCs cannot be used for the biggest cancer that is responsible for almost a quarter of all referrals on cancer. So my question is, how do we tackle this type of silo working to ensure that we're maximizing the investments and not missing out any kind of opportunities?
Many thanks. Would you like us to group some questions, perhaps? Let's do that. So perhaps if we just go to the gentleman on the back row, just there next to us, close, and then we'll come to someone a bit closer.
Hello, my name is Daniel. I used to be a Preston City councillor. What I'd like to ask, a couple of things that touch me personally, is obviously a lot of things like cancer and Alzheimer's get a lot of press when it comes to diagnosis. But where my point comes from is things like hidden disabilities such as autism. I've got autism myself. I was diagnosed very late, and the waiting lists for getting diagnosed with things like autism are very, very hard. We have a 3-year-old daughter, and getting her diagnosed is really, really hard. Unless you go private, and also the support services after you're diagnosed. You might get 6 sessions of counselling after you're diagnosed, and then you've got to bid again for funding. So it's, you build up trust, and especially with people with autism, it's very, very hard. Another thing that also touches me is chronic pain. I'm in a lot of pain constantly with my hips and my knees. Now, I've been on a lot of opiates and a lot of controlled drugs for 10, 12 years now, and I'm only 30, but that touches me, and the diagnosis is into that as well. And I just feel the GPs and the prescribers, they're just stuck with me at what to do because I'm so young, and I've just been stuck on a lot of controlled drugs for so long. So they're my questions, really.
Thank you very much. If we just take one more. Can we go to the gentleman on the second row from the back, just on the aisle, and then we'll come forward and capture some of you guys in a second. So, name and organisation, please.
Thank you. Fabio Conti, I'm a member and I'm a GP. It was just on the expansion of testing, especially sort of rollout of tests that people do at home and screening tests, is the education that has to go in terms of empowering patients, not just to understand what a positive test mean, but a negative test as well. I think a really good example is bowel screening. So the positive, the level that it's set for a positive test on screening is very different to the fit test that you do if you come to see your GP. I had a patient recently who had symptoms of colorectal cancer, but had done a screening test at home. It was negative, and thought, well, I don't have to go to the GP. I don't have to worry because my test was negative. So especially with an expansion of testing at home, it has to come with a piece of education. And in particular, closing the gap in terms of health inequality. Often when it comes to breast screening or bowel screening, people who essentially maybe are less affluent, etc., are less likely to do those tests. So how do we target those? I work in a deprived part of West London, and we do a lot of work with people, especially where English isn't their first language, in terms of why they need to take those screening tests and chasing people up to do them. But how do you do that at scale to ensure that you target those people as part of it and they're not left behind?
Brilliant. Well, thank you very much. Yeah, 3 really interesting questions. So the point around the siloed approach and perhaps the major condition strategy will be useful in that regard. And the question around other services where diagnosis is a really key component that we've maybe not touched upon yet. And then this point around health literacy is really key. So maybe Neil, if I come to you first off reflection.
Sure. So in reverse order, I thought Fabio's both of his points are very, very important ones. So how do you get more people tested in areas where people don't test? I mentioned the lung health check. I mean, that started in the city with a bunch of buses that took lung health checks to the most deprived areas. That has got to be the model for the future of the NHS on things like blood pressure checking, a very simple check in one sense, through the pharmacy first that the Prime Minister announced earlier in the year. We're going to have a huge expansion of blood pressure checking in your pharmacies, and they are disproportionately concentrated in areas of deprivation, and so that will make it a lot easier for people if they're popping in to get some strepsils to get a blood pressure check on the side, and that will potentially save quite a lot of lives. And that is the model of those community and employer situated kind of tests that I think we need to go down in the future. And you are absolutely correct about the need for education to go with the rollout, particularly of home diagnostics. So there's a gentleman in the background. I'm terribly sorry to hear about your chronic pain. That sounds awful. But yeah, absolutely. In terms of mental health, including autism, we are, as you know, putting in several billions more as part of trying to create parity between physical and mental health. And I hope that will be a part of the answer to the question of how we get those diagnosis delays down and the level of treatment that you talked about up. And in terms of breast cancer, absolutely, we've got to, obviously it's arranged in terms of cancer networks across wider areas, and we've got to make sure that we don't let anything fall between the cracks. So I'm happy to continue that conversation after the session about how we do that, and to talk further with my colleague Helen Waitley about how we make sure that all joins up in a seamless way so that we get the advantages that we should get from this huge investment in kit in terms of breast cancer as well as the other types of cancer.
Thanks, Neil. John, I wondered if you do any of those points you wanted to pick up on.
Yeah, thank you. There are a few very important points there. Firstly, that the really important point that it's not CT scanners and MRI scanners and blood tests that make all diagnoses. There are many diagnoses we make for clinical assessment. And those are of equal importance, and there's a risk they'll get left out of this debate. And likewise, that the treatments, are not always drug treatments or surgery, but wider treatments are equally important. On the point of diagnostic centres and perhaps some elements of that being siloed, I do think that's a really, really important point. And indeed, we could look at health education, health literacy around testing as, again, potentially being siloed. And what is fundamental is that local places, local communities are joining these things up. So that the local diagnostic centre is seen as part of the local health and care system. The local authorities and voluntary sector will have a big role in the education around those tests and enabling people to access who might otherwise find things accessible. And the specialists, how they link, with some of the screening and advice or local champions for disease, how they connect that to other services that people might need when they've been through diagnostic tests is essential. So one of our biggest challenges, one of our biggest wastes in healthcare at the moment, health and care at the moment, is that we do still silo these things. We still do put, a sticking plaster here and there, rather than local systems designing health and care for breast care or for people with chronic pain or whatever it may be. So yes, local health and care and local authority taking ownership for what those local elements of care and how they're connected is essential, and the education component has to override all of that.
Susan, did you want to comment on it?
Yeah, just a few points, and obviously others have made some really useful points already. I think that point about silos is really useful. There are so many examples. To come back to dementia, we know that many old age psychiatrists work in mental health trusts. They can't access the PACS scanning system to look at some of the scans they've requested. It's a small opportunity, which, it doesn't feel like the hugest barrier. We should be able to overcome some of these things. I know there are always challenges, but those are the kind of things that create the siloed working, which create the problems. I think the point, from the gentleman at the back, is the reality that many people live with multiple conditions. And again, it's not just the structures, but it's how we come to people and look at them in the whole holistically. With dementia, most people have other health conditions. You're not going to manage your diabetes drugs very well if you keep forgetting to take them. So, we've got to think about the impact of one disease on another. And also to be a bit challenging. I think some of this, we can be a bit paternalistic about some of this when we're thinking about scale and outreach. Great, let's use digital health checks. Let's use different ways. We can enable people who are willing and able to take those opportunities. But I think at that point, we can't just assume they're going to come to us. We need to look at better ways of reaching a whole range of people. They're not hard to reach, they're just seldom heard, seldom seen, and for a whole set of good reasons, they've got other things going on in their lives. But if we can use, and I think this is where things like data comes in, where are the data gaps in diagnostics? Who are the people not getting that diagnosis? How do we target them with what will work for them, whether that's through their employer, through their community groups? There are lots of great, very small-scale local projects which engage different communities with different health conditions with huge success. It's as ever, how do we learn the lessons and build those together to find what works for different communities? And even then, that's generalising because each group is itself hugely heterogeneous, and we shouldn't assume that what will work in one place will be another. But I think there's huge opportunities there, and it's about, as ever, the NHS is stressed. How do we step back, have that strategic view, and actually join the dots, which I think could have such impact?
Here. Would you like to comment on any of these points?
I was interested actually in the GPs there, sorry I didn't catch your name, Seb, but your point about the false reassurance of tests, which I hadn't thought about actually. But it does make me think of how, you know, when one sort of receives one of those tests at home, that there is some written material around it, but you might very well choose not to open it. There's obviously huge resource implications in thinking about having, you know, a sort of communication campaign around it, but perhaps that is something that we should think about, and I guess hopefully those tests are going to be getting more and more effective as the years go by. So the point hopefully will wind up being fairly moot eventually, that you wouldn't get a false reassurance, but an accurate result. But I think there's really something to think about there actually.
Super. Many thanks. So we've got time probably for 3 more questions. So if you keep them brief, we'll be able to squeeze them in. So perhaps if we go for this gentleman in the middle aisle, and then if we come over here, and then one over here. Name and organisation, please, first.
Richard Angel, the Chief Exec of the Terence Higgins Trust. Neil said that good things don't get celebrated, and one of the things the government have invested in is opt-out HIV and bloodborne virus testing at A&Es in London, Brighton, Blackpool and Manchester, and it's having absolutely amazing effect. We're looking for 4,400 people in England with undiagnosed HIV, and that one programme's found additional 500 people just in the first 16 months. So it's a really amazing thing. And the Minister knows we want to see it rolled out in more places, and there's probably another time for that. But I think what's the interesting lesson from that programme is that those experiencing some of the harshest health inequalities are sitting in our A&Es and waiting for a very long time. And if you miss that opportunity, that when they're at the front door of the NHS and you don't test them for a series of things, one of the good things that can come from waiting in A&E is you probably do a pee, a poo, and you can leave some blood while you're there. And in that process, we could diagnose people for lots of things. And so sometimes we do outreach, and the Minister talked about our testing week and finding 22,000 people to test for HIV, and really good return rates on finding people and get them on a pathway to care. So outreach matters, but often they're situated at the front door of the NHS already. And if we can move the test to an A&E or when they register with their GP, we could do an amazing thing for health inequalities in one go, not just for HIV, but across a whole series of conditions.
Super, many thanks. Perhaps if we go for the gentleman just in the second, the third row at the end, actually, if you get it, the gentleman with the glasses. The mic's just coming to you. One moment.
Thank you. I'm Tony Johnson, and I'm on a number of committees, including on Dementia Champions Stockport. The concern I have is that it's now 9 years since Health and Social Care was devolved to Greater Manchester. We've heard nothing from Andy Burnham in relation to quick wins, synergies, money, savings that could be made to recycle services. Now, as far as dementia is concerned, what is interesting is to compare the performance of the 10 boroughs in Greater Manchester. So after 9 years, we've got a disparity between the diagnosis rates of each borough, the lowest being Trafford, which is below the target for the national. And if I also look at the rates for the prescribing of antipsychotic drugs for those with dementia, you'll find that Bury's got double the rate for Trafford. So what we want to do is actually makes some kind of accountability so people know that Andy Burnham's not doing his job to get on the levelling up.
Many thanks, sir. And perhaps we just go for a last question. Could we go to this lady just in the second row, please? And then I'll give our panellists the opportunity to give some closing remarks and to reflect on all those questions. Name and organisation, please.
Thank you. Beth Colity from the charity Versus Arthritis. So 10 million people in the UK have got arthritis, but many of them have not had a meaningful conversation about that diagnosis. So how do we, when someone gets a diagnosis, how do we make sure that conversation is more meaningful to them, it's well understood, they understand what they need to do next?
Super. So, yeah, lots to consider there. So perhaps if we start with you, Neil, and you have the opportunity to reflect on any of those points that have been made.
Some great points. So in terms of Manchester, I think, obviously I have a radical preference for the Mayor of Birmingham over the Mayor of Manchester, but the health system here, through no particular fault of the mayors, has done some interesting things. I mentioned the lung health checks in vans. If I think about other things like dentistry, where they have recently established a new patient premium that is driving up access to dentistry here. Other things that we've borrowed from here, like the smoking in pregnancy incentives, which are really helping to cut the number of people who smoke in pregnancy. There have been some good innovations out of Manchester, though it's in truth very little to do with the mayor. And on the last point there, I think I'll leave it to fellow panellists to better address that, I think, rather than me.
Sarah,
yes, no, I think that's it. Well, I always urge people to take their chance to vote Mr. Burnham out whenever I get the opportunity, and this is one. So the next time that people here get to vote, I'm sure they'll consider that as well as everything else about the system.
Lovely. Many thanks, Neil. Sarah.
Yes, I think journalistically it would be good for me to take a look at, you say it's 9 years of combined health and social care in Greater Manchester. I hadn't realised it was so long, actually. I wouldn't want to comment without looking into it as to why there are such big disparities between boroughs, because presumably there may well be some socio-economic reason for that. But I think it was a massive and sort of groundbreaking experiment when it started. So it would be good to take a look at that in more detail. Sorry, what was your point?
Yes. Ongoing conversation once they've had diagnosis.
Yes, not feeling that they're sort of abandoned. Yes, because that's something you often hear about dementia, actually, isn't it? That people get a diagnosis and never again, have any sort of contact with the system. I mean, arthritis is obviously rather different, but it's. Do you think it's a situation though where it could be ripe for quite a lot of peer support? Because one of the things that I think happened during the pandemic was there was quite a sort of expansion of kind of peer support, people feeling that at the time when they weren't able to access clinicians very easily, they were finding some sort of comfort and advice from within their own group. I don't know what you think about that, but it's I thought that was quite an interesting development during the pandemic, so maybe it applies here to some extent.
Super. Thanks, Sarah. And then just the final word from John, and then the last word from Susan.
Yes, I'll pick up two points from those. Firstly, from our colleague from the Terence Higgins Trust, I think your point is extremely well made. Those who are most vulnerable for their health are hitting the health service, and yet we're not directing or picking up many of the issues that can help them. And I think as healthcare professionals, we all have a responsibility to do that. So if I see someone that has a risk in an area outside of what I'm treating, I think I have responsibility to be able to signpost them and highlight that to them. And I do think the joined up information systems give us the real opportunity for that. We see that in health systems in other parts of the world, where actually whoever that healthcare professional is seeing the individual, it highlights what their risk areas are, what the screening opportunities might be that they may not have accessed. And they are seeing someone who they might see and respect, who can target them to that. So I think your point is extremely important. And in terms of the arthritis, again, it comes back to what I was saying about the support and services that need to sit between primary and secondary care, of which education support and supporting people to live with long-term conditions is essential. And it falls between the two at the moment, rather than sitting as an opportunity for people who have those diagnoses. And undoubtedly, good education, peer support as part of that, but accessible to people wherever they have their diagnosis is what's required.
Just in terms of the comments about dementia, I think you make a really fair question about accountability, and I think it reflects the fact that we don't value dementia sufficiently in this country. We think it's okay that many people don't have a diagnosis. There is very little data on this. There's actually very little sort of scrutiny, and the little data we have isn't hugely accurate. The basis of those estimates is actually really quite poor when you dig into it. So I think there's an opportunity there. We need better data. We need to know that health professionals are able to kind of capture that data fully. Obviously, there's a local conversation about accountability in a local area, but I think we should support systems. I think many services do want to improve dementia diagnosis, but it's quite hard, and if people aren't coming forward, they're not able to find them. I guess my final reflection is it's really interesting. I think there were really interesting questions, whether that's what's happening in A&E, what's happening with support. And as ever, so much of this is about us getting beyond individual conditions and trying to join up. The support services need to be common for everyone facing a diagnosis. Many of those things require social care support, counselling, peer support, depending on your condition. And I guess that's the opportunity. How can we make it more than the sum of its parts?
Many thanks, Susan. I'll give the final word to the Minister.
Actually, the point made by Terence Higgins is actually an incredible example of the potential power of diagnostics and why such an interesting discussion today. Because I think about two things that are happening there. You mentioned the HIV opt-out testing in hospitals, where we're doing something we've got to do more generally, which is use those touch points we've got with people to test for things. And as well as finding the 500 people with HIV, it's found more than 2,000 people with other diseases, including Hep B and Hep C. And I met one of them, this guy in the Royal Navy, goes to A&E with something completely unrelated, an injury, discovers that he completely unexpectedly has HIV, and that guy's life could have been completely destroyed, and just by pure coincidence, he was found. So that gives you one type of the power of diagnosis. But the other, of course, is the thing that we're actually doing with Terence Higgins, which is posting people at home HIV tests. And again, this is something where there's still a huge amount of stigma, there's still a huge amount of people who don't come forward for testing. And if I think about the journey of HIV since the early 80s to now, the fact that you can now go on the internet or perhaps through DHSC and Terence Higgins, order for free a test that you can conveniently do at home to test for this thing and find out whether you've got a potentially life-changing illness, is such a transformation on where we were, if you think about it, in the 1980s. Just diagnostics there are transforming the lives of huge numbers of people. So it does give us a note to end on of just the incredible power of diagnostics and why it is that we are so keen to do more.
Yeah, absolutely. An optimistic note to close on, and lots of food for thought and discussion. And from my perspective, just to say enormous thanks to Alzheimer's Research UK for their support of this event.
Yeah.
Thank you very much for attending the first event. And Neil, in your opening remarks, you talked about Barnwell's cost disease and about increasing costs of workforce over time. And indeed, that subject about how the government will deliver its long-term workforce plan is going to be our next discussion. So please do stick around. But in the meantime, please do join me in thanking our fantastic panel, and have a good conference.